If everyone could take your seats, we're going to get started in a minute. Thank you. The House Health Policy Committee will come to order. Will clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett.
Here.
Carter.
Here.
Hadsma. Neely. Here. Glanville. Coffea.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingans.
Here.
Vanderwall.
Present.
Filler. Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 17 members present. You do have a quorum.
Thank you. Representative Conlon moves to approve the minutes from our meeting on September 28. Seeing no objection, minutes are approved. Today we have a relatively full agenda once again, so I am intending to move very swiftly and efficiently. First, we have a vote on reporting SB 384, followed by HB 4101, which has an H1 substitute with some minor changes. And after voting to adopt the sub and reporting them out, we will then proceed to House Bills 4213, 4579, 4580, and 4131, which pertain to telemedicine, and we will take up all four bills together as a package. We will have substitutes for these bills to bring them in agreement with each other. We will then proceed to hearing testimony on House Bills 4504 and 4505, which would have Michigan join the Physical Therapist Licensure Compact. Finally, we will take up the Occupational Therapist Licensure Compact Bills HB 4169 and 4170. First up, we have SB 384, and Representative Neely moves to report out SB 384 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma. Neely.
Yes.
Glanville.
Yes.
Coffea.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Let's pause and start over again, if you don't mind, please.
Chair Rogers.
Yes.
Reps Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Coffea.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. Senate Bill 384 is reported with recommendation.
Motion carries. Next up, we will take on House Bill 4101. We do have an H1 substitute before us. Vice Chair Vanderwall, would you mind sharing the changes that are contained in that H1 sub with the committee?
Absolutely, Madam Chair. Appreciate the opportunity. There's two changes in the sub. One is that it's a 180-day implementation through the department, and it takes it down from 3 renewals to 1 renewal opportunity. That's the two changes in the sub.
Thank you very much. Representative Thompson moves to adopt the H1 substitute to HB 401. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Coffea.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. The substitute is adopted.
Representative Mueller moves to report House Bill 4101 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. House Bill 4101 is reported with recommendation as substitute H1.
Congratulations, Minority Vice Chair. I love these unanimous votes. Now we will hear testimony on House Bill 4579, introduced by Representative Price, 4131, introduced by Representative Liberati, House Bill 4213, introduced by Representative Morse, House Bill 4580, introduced by Representative Brabeck. If you would all like to join us. And I think Representative Price will probably lead off, but welcome to House Health Policy Committee.
Thank you, Chair Rogers.
I'm sorry, we are going to first pause and adopt in the sub so that this conversation makes a little bit more sense. So 1 second. Representative Reingans moves to adopt the H1 substitute to HB 4131. Madam Clerk, will you please take the vote?
Chair Rogers.
Yes.
Representatives Witsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall.
Pass.
Filler. Mueller.
Pass.
Van Workum.
Pass.
Roth.
Pass.
Schmaltz.
Pass.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 6 pass. The substitute H1 to House Bill 4131 is adopted.
And then next we have Representative Conlon moving to adopt the H1 substitute to HB 4580. Madam Clerk, please take the vote. Conlon, yes.
Chair Rogers.
Yes.
Representatives Witsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall.
Pass.
Filler. Mueller.
Pass.
Van Workum. Roth.
Pass.
Schmaltz.
Pass.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 6 pass. Substitute H1 to House Bill 4580 is adopted.
Thank you. Now we will have Representative Price kick us off.
Thank you, Chair Rogers and members of the committee for giving me the time and opportunity today to speak on my bill, House Bill 4579, which amends the insurance code and creates telemedicine parity. And I'd like to also take a moment to thank my colleagues here for collaborating on this package, especially Rep. Liberati, who has been leading the charge for telemedicine parity for years. I'm very grateful for his work on this and for including me as part of this package. So my bill is pretty straightforward. It ensures that appropriate telemedicine services are covered by insurers as if the services were provided in person. In other words, the same service, whether it's provided in person or via telemedicine, would be reimbursed at the same rate. And I just want everybody to note, this legislation does not impair an insurer's ability to negotiate prices for services. It also isn't the intent of this legislation to replace necessary in-person services with telemedicine. This legislation is about expanding access to quality health care, which may not otherwise be able to be provided because of lower telemedicine reimbursement rates or complete lack of coverage for services delivered in this way. Telemedicine parity is especially important for underserved populations who face provider shortages, stigma, lack of childcare, and lack of access to reliable transportation or high-speed internet. Creating telemedicine parity is especially important for the delivery of behavioral health and addiction treatment services. At the peak of the COVID-19 pandemic, telehealth represented 40% of mental health and addiction outpatient visits. And since the end of the public health emergency, patients have been losing access to this care. The pandemic demonstrated the importance of expanding telemedicine access. The providers who are joining us here today will speak to its effectiveness and the positive impact that it has had on public health. Telemedicine parity will increase access to care, enable more preventative treatments, and aid effective management of chronic and mental health conditions. And look, what we're trying to do here today is not new. It is exactly what we were doing during the pandemic. During the pandemic, we had telemedicine parity, and it worked. We simply seek to codify this increased access to healthcare into state law on behalf of all Michiganders from every corner of the state to improve their access to quality care and improve their health outcomes. Thank you.
Thank you. I think Representative Tullio Liberati is up next.
Thank you. Representative Price hit on pretty much everything on that. My part of the bill just dictates that health insurance policies can't dictate how you're going to have your service done. If it's going to be in-person telemedicine, I just feel that's better the providers and the patient to work that on.
Thank you so much. Representative Morse.
Thank you, Madam Chair, members of the committee. I am thrilled to be here today to offer House Bill 4213, which amends the Social Welfare Act to require that Medicaid and Healthy Michigan cover telehealth services. And this is important for all the reasons that my colleague indicated, but I want you to think about what we try to do and what we talk about all the time in the area of healthcare is accessibility. And accessibility is an issue for many reasons. We don't have enough providers. People have transportation issues. People have difficulty obtaining insurance in the first place. There are so many reasons, or they live in a rural community, right? Where they have to drive really far to even get to the doctor if they have a vehicle to do it. So giving people this opportunity, which is so present in our society in how we communicate, period, just makes sense. And it is such a simple thing to increase accessibility and allow our medical providers to provide as much care to as many people as efficiently as possible. And when I came in here this morning, I was talking to some primary care doctors, and I thought, and we talked about the fact that if we can just call a doctor and say, I'm having these symptoms, and he can order you some antibiotics versus showing up in an ER, how much that's gonna cut costs and increase accessibility just across the system. And the final thing I'll point out is for behavioral health, we know that a stigma still exists and that a lot of people don't seek out care because they don't want to be seen walking into a counselor's office. And so the fact that they can do it from the comfort of their home where they do feel comfortable, just when we are continuing to have a mental health crisis and we don't have enough behavioral health providers, it's just another way to ensure that we are providing as much access as possible for our system. Thank you.
Thank you. Next, we have Representative Felicia Braybeck.
Thank you so much, Chair, members of the committee. Thank you for having us here. To my colleagues and fellow co-sponsors, I'm so excited to work on this package of bills. And my colleagues have done an amazing job explaining what the package does. I'd like to share with you a little bit about what it's like as a provider. Many of you know that for 30 years I've been a mental health care provider, and telehealth is a necessary part of the tools that we have to be able to serve folks. And so, one of the things, as Rep. Price already mentioned, was the numbers that when we saw the uptick in telehealth use during the pandemic. Well, and that's here to stay, right? Like, folks became accustomed to that. That was a mode of communication and treatment that was much more appropriate for some folks. And you'll hear from other providers today those specific examples. But part of what helps make that accessible is the fact that it's people are comfortable. There's the stigma issue that folks have to manage all the time. I was having a conversation this morning with both Reps Thompson and Schmaltz about stigma in mental health care. And if we can do things to be able to mitigate some of that, this is a way to do that, and I think that we should. So we have, in terms of folks who this could help, just general folks who are seeking services, but particularly folks who have disabilities, folks in rural areas, folks who have connectivity issues, like if we can get them connected and have them in transportation issues more explicitly, that helps us. But also people, in terms of the clinical part, people suffering from depression or anxiety or agoraphobia or panic attack. Things like that, if we can actually, if I as a provider can have access to talk with them in a setting where they feel most comfortable, we generally can have a lot more success in the work that we do. Rep Morris talked about this, but two of the main things that we're continuing to work on with our mental health care crisis are access and workforce. When I got to do the listening tour throughout our state, those were the two things that kept coming up over and over and over again. And one of the things that I share with colleagues all the time on the Behavioral Health Committee is when we work on these issues around mental health care and subabuse prevention and treatment, we need to think of the solutions in a multi-pronged fashion. Not one thing is going to help, but it's going to be all of them collectively together that's going to help us solve this crisis. This is another tool. These bills and this package are another tool in us being able to address the mental health care crisis. And as folks talked about before, this package of bills helps codify the use of telehealth, what we were doing during the pandemic, so it helps us codify that. But also, and I want folks to keep this in mind, two things. Rep. Liberati talked about this. I think it was you. I'm sorry, maybe it was Rep. Morris, one of us. That insurance companies can't mandate telehealth only. There is latitude in this package of bills for folks to be able to make those determinations. And I can share, as a provider, that is one of the most efficacious things for me to be able to do when I get to work with a client, is to be able to have that latitude to figure out when and how with my client. And this package of bills allows us to do that. And I'm so proud to sit and stand with my colleagues and the providers who are here in the room to move this forward. Thanks so much, Chair.
Thank you. So I think we're going to take some questions, and then once the questions are done for the sponsors, then we'll go on to the next testimony. But I know Minority Vice Chair Vanderwall has a question that will lead us off.
Thank you, Madam Chair. And again, thank all of you for being here today and bringing this issue back. It's been something that's been worked on a little bit in the past. So thank you for being here. Just a couple things. And as we go in and, as we look at telemedicine, there's a couple pieces that in this bill that give me a little pause. First is, how do we control the period of time between visits so that we can control the cost? Because once you make it very simple, there is a tendency that they could have doctor's meetings every 2 weeks instead of once a month, just to control costs. And how do we justify that? The second part of that, when you have an in-person visit, there's a lot of times that you can diagnose another issue that a patient may have that you would not normally have if you only did telemedicine. My question is, inside these bills, what have you put in place so that it's not a 100% telemedicine visit all the time?
Representative Price.
Thank you for the question. That's an important one. You could probably tell from listening to my statement that a lot of my interest on this is related to addiction treatment and behavioral health. I do recognize that there are different elements of healthcare providers that need to meet in person regularly for certain services. I am not a healthcare provider, and I don't pretend that I know how appropriate it would be for a healthcare provider to meet in person at certain amounts of time for different conditions. That's not on me as a legislator to decide. What is already in place and what we were very careful not to change is the ability for Laura and the accrediting boards of providers to promulgate rules related to those areas. So orthodontics, right, is an area where I would assume it would not be appropriate to have only telemedicine, right? We can all jump to that extreme. But that is up to the Laura and the accrediting boards to promulgate the rules related to the necessary in-person frequency for certain services provided by certain providers. And these bills do not take away that ability for the providers to make the decisions about the appropriate way to deliver care.
Thank you, and I think Rep. Morse wants to chime in too.
So in addition to that, we have national standards of care that anyone who's practicing in the medical field has to take into consideration in addition to licensing. And they also are always under threat of medical malpractice, right? Like the system already has these things built into place. And we as the legislature are not here to tell physicians the appropriate way to practice. That is dictated by their profession and Lara and the national standards of care that are set. So in my opinion, I think that we as the legislature should not be saying you have to meet once a year or whatever, because that may not be appropriate. They need to practice according to the standard of care.
Thank you. All right, next up we have Representative Conlon and then Reingans.
Thank you, Madam Chair. Thank you for your testimony today. You guys have failed to mention one area, which is the elderly and how they benefit from this. My 89-year-old mother lives with me, and I'm her caregiver, and it was extraordinary during the pandemic to be able to move her to telemedicine. And, 2 weeks ago, she wasn't feeling well. I wasn't home to take her. She thinks she can drive, but she can't. Hopefully she's not watching. And so we're not comfortable with her driving. Obviously, her other caregiver that sometimes there wasn't there. The doctor wasn't, even available, and it was a workforce access issue. She was able to get on the phone. She had a practitioner, and they were able to sort her out and just have me pick up the medicine on my way home from Lansing. So it's extraordinarily helpful with the elderly. Is it okay just to be on a phone, or does it always have to be, that's my one question.
Representative Price.
Yes, thank you for bringing that perspective, and I apologize to your mom that I failed to mention that essential element of our people that need service and can get more access through this. This question of is phone only, audio only included? Yes. By definition, in our current law, telemedicine by definition includes audio only. So as much as I wanted to add another asterisk saying that explicitly, the attorney said no need to, it's already included. Again, whether it's audio only, video, or in person, our goal is that is up to the provider. What is the best way to deliver care? And the services need to be reimbursed at the same rates regardless of which of those three modes are used to deliver the services.
Thank you. Representative Reingans and then Glanville.
My question was a little bit similar to Rep. Vanderwald about not as much worrying about cost of frequency, but more about need to get eyes on people, especially if we're talking about things that happen to our bodies. A 3D interaction sometimes can be better. When I worked during the pandemic for the Michigan Department of Health and Human Services, as we were debating how to switch our Medicaid state policy to allow for the reimbursement of telehealth services and telemedicine services, at the beginning of the pandemic and then near the end of when I was serving there, we were trying to figure out what is the right mix of in-person versus only remote, and how long do you stay remote versus asking somebody to come in. And so I wasn't concerned about it from a cost perspective at that time. It was more of a minimum standard, but you mentioned they need to follow standards of care. And so we as legislators can't legislate in our law the exact amount, but make sure that it adheres to standard of care. But also, it's not just Lara that sets some of this policy, it's also MDHHS. So don't forget that they are also trying to establish some of this. So that's kind of what I wanted to add, was that our own State Department also oversees some of this. So thanks.
Thank you. Representative Glanville.
Thank you, Madam Chair. And I really just have a little bit more of a comment. I wanted to go back to something that Representative Morse mentioned about the ER. And I was in a meeting with some other folks with emergency room physicians just last week. And, the amount of burden that our emergency rooms already handle. I feel like if we could take away the idea that folks who don't have health care go to the emergency room, that is their primary care physician, right? And so I'm just imagining that this would really, hopefully would make a noticeable difference in that caseload for them, that folks, would have a way to access medicine that is appropriate to what they need and what the hospitals can support. And I also just want to add on a personal note, I personally benefit from telemedicine, right? I don't know if anybody else here, has had the opportunity to email their doctor or jump on a telemedicine call. Or something like that, especially if you have, I don't know, maybe a slightly busy schedule, it can be, you can squeeze that in. So I just think, this really reaches, we talk about how folks, the pressure on our healthcare system and all the things, and I really see this as an avenue for providing some relief across the board. So I really appreciate you bringing this forward, and thank you for the latitude there, Chair.
Thank you. Representative Farhat.
Thank you, Chair. And, I have a question that pertains to the cost of visits via telemedicine and the cost associated with visits in person. Just looking at it, the common, maybe it's a misconception, that's my question, is that wouldn't it be cheaper to just do telemedicine than an inpatient? How are costs when you break them down for these two types of visits? Dr. Braybeck.
Sorry, Representative Braybeck, I have a couple things going.
Sorry, Chair. I wanted to be deferential.
Thank you. Go for it.
Thank you. Thanks for the question. As a provider, to me, there's no difference in cost. Right? I still have my space that I provide services. I still have malpractice insurance. As Rep. Morris was talking about, that we are bound by all these things. I still have, the software that I use for billing. Like, all those things are still the same. Those don't change. Rather, whether I see someone in person or via telehealth. And so I believe that that's a misconception.
Thank you, Doctor.
Sure.
Thank you. Representative Kofia.
Thank you, Madam Chair, and thank you, colleagues, for bringing this important legislation forward. It's more just to echo. I represent a rural district in the north. Some of the things that you named are just resonate so hard with me. Public transportation, right, access, providers. So I appreciate the idea that we're going to ensure that our providers up north and anywhere in rural Michigan can get the same level of coverage, insurance coverage, so they have the flexibility to work with patients for what they actually need when really the barriers are so real. Internet as well, right? We have areas with huge holes in any sort of coverage. So just to validate and appreciate that I think this is, the idea here is giving our healthcare providers the full tools that they need to give the care that Michiganders need no matter where they live. So thank you.
Thank you. Representative Roth.
I'm going to jump on Representative Farhat's question too, that I can understand mental health services being similar over telehealth or in person. I'm more concerned, I guess, with physical health. There are chances it could save money and cheap if we have a small mental health, or excuse me, a physical health teleconference. We could save money over actually coming in person. Are we suggesting that all those should be the same?
Representative Price.
Yes, this was a common question when I was reaching out to stakeholders to share my ideas related to this. And we have clear research that shows that the cost to the provider for providing even things that we traditionally associate with physical health through telemedicine tools as opposed to in-person it's a negligible difference. If you think about it, it requires the same level of expertise, the same level of paperwork, same malpractice insurance. So again, system-wide, there is no significant difference in cost to the providers, whether they're using telemedicine or in-person for visits. And I also want to say that because of the protections that were put in place that makes it so that insurance companies cannot require telemedicine, the cost of having that option of a clinic, of a hospital, of a space to see patients in person will not go away.
Representative Morse wants to add on, I think.
Yeah, that being said, all of this continues to be a negotiation between the insurance companies and the providers as to what the rates will be set at. So yes, there is parity, but yeah, it's a yes and that will continue to be negotiated as part of the system. Yes, as part of it now. Yeah.
Thank you. Representative Miller. And then we're going to move on to our next group of testifiers. Thanks.
Thank you for bringing this forward. I have a telemedicine appointment tomorrow. I've had surgery. Look, I can't get in to have it checked. I have a job that I have to be at that I absolutely love. So having this ability to be able to have this online is just so important for so many. My question is, now it was brought up, can other things be diagnosed? I'm just going in for one thing only. This can't be used, nothing replaces having your heart listened to. So those appointments are separated, but how is that defined as to what's telemedicine and, where's the line there?
Representative Morse.
I would just repeat that it's regarding the standard of care. I mean, every physician has their national standards of care that they have to comport with. So it's about the doctor knowing what is appropriate for that patient and the level of care that they need. And if they need to be seen in person, then that doctor should be doing that.
And we are talking a lot about physicians and doctors, I just want to take a chair's point of privilege that this is not exclusive to physicians, includes other healthcare professionals, not just physicians, even though we love our physician friends that are in the room. Thank you so much. All right, if you all bill sponsors would like to vacate, thank you so much for joining us. Next up, we are going to have Philip Bergquist, CEO of Michigan Primary Care Association, and Dr. Nikhil Hamidi, Chief Medical Officer for Honor Health, as well as Dr. Kevin Bonsack with the Michigan State Medical Society. And you can all come up and begin when you are ready. And 1 second. And I would like to recognize folks in the room that have joined us recently from the Michigan Psychiatric Society. Thank you. Please do not clap or I will have to gavel you, Minority Vice Chair. Maintain decorum. Begin when you are ready.
Well, good morning, and welcome to everybody in the room, too. Philip Bergquist, I'm the CEO of the Michigan Primary Care Association. We represent all of the community health centers in the state of Michigan, sometimes known by their more formal name, federally qualified health centers. We serve about 1 in 15 people in the state of Michigan in a comprehensive range of services, integrated primary care as a foundation, but also behavioral health, substance use, oral health services, and a variety of other things across the state. Very nice to be able to speak with you this morning. In 2020, we've talked a lot about 2020 so far. We pretty dramatically scaled up the provision of telehealth services to really help our care teams engage with patients. And we've kept those telehealth services going. We've learned from what we did in 2020, expanded upon those services, and really grown into a more stable and ongoing use of telehealth services today. Since the sort of growth period of the pandemic, if you look at it today, statewide, about 10% of the services that health centers provide are provided through telehealth services. And to some of the earlier questions, both audio-video telehealth services as well as audio only, both of them being very important. While telehealth represents a small portion of what we do, so 10% is a small portion, it's really important. And for the patients that engage with their care teams via telehealth, there are many barriers and factors and considerations there. And so for that small group of folks, we're speak today on behalf of in support of these bills. I'll turn things over to Dr. Hamidi for a few minutes and then wrap things up from there.
Thank you, Madam Chair, for having us this morning. Members of the committee, my name is Dr. Nick Hamidi. I'm a family physician. I've been practicing for about 24 years in Michigan, primarily in underserved Michigan. So we're here, of course, in support of House Bill 4213, which would codify several important aspects of providing telehealth services that have not only proven effective in the last couple of years, but we believe will continue to be essential to the long-term sustainability of telehealth care. The bill ensures many types of telehealth services would continue to be covered by Medicaid and Healthy Michigan, which allows telehealth to support service integration consistent with our focus on the integration of in-person services. The bill provides coverage for both audio-video and audio-only telehealth services, which is critical for patients who do not have access to or cannot afford high-speed internet. While we continue to prioritize face-to-face interactions for a significant majority of health center services, some interactions between a patient and their care team can be managed successfully using audio-only telehealth, and our clinicians exercise appropriate judgment in determining if and when that is appropriate. Discontinuing audio-only telehealth would isolate areas of the state and certain populations from telehealth care. Furthermore, while broad telehealth outcomes continue to be formally evaluated, our preliminary examination of several common quality measures like hypertension control, diabetes blood sugar control, tobacco use counseling, and depression screening for patients who received at least one audio-only telehealth service showed little difference in the quality of care compared to patients with audio-video visits. The bill ensures Medicaid providers are reimbursed at similar rates to in-person services for telehealth care they provide. We've looked closely at the resources needed to provide telehealth care and have not found meaningful cost savings compared to similar in-person care for most providers. CMS continues to indicate federal matching funds will be available for Medicaid telehealth services, including audio only. And because the bill is focused on Medicaid and Healthy Michigan, covered telehealth services would continue to be accounted for in rate development for health plans. And finally, the bill protects providers like health centers from the complexity of additional constraints being placed on telehealth services like certification, location, and training requirements or other limitations. Thank you again for this opportunity this morning. Thank you.
Thank you.
Chairman Rogers, Vice Chairs Whitsitt and Vanderwall, members of the House Health Committee, thank you for the opportunity on behalf of the Michigan State Medical Society in support of a crucial package of bills that seek to ensure equitable reimbursement for telehealth services. This legislative initiative is a pivotal step in securing the future of healthcare delivery and patient access in our state. My name is Kevin Bonesack, a family doctor. Good to see another family doctor here. Trained 25 years ago in the Upper Peninsula. Several different roles since that time in Michigan and around the world. I precept family medicine residents and serve as the Executive Medical Director of Population Health Management.
I'm so sorry to interrupt. Can you make sure your microphone's on?
I don't know how to do that.
Push the button.
I'll push the button.
Thank you.
There you go. All right.
You can just continue.
Meet and greet. Dr. Bonesack, I'm a trained family doctor. I trained in the Upper Peninsula with several roles here in Michigan and around the world. I precept family medicine residents and now serve as a Population Health Management Executive Medical Director. I'm also a board member of the Michigan Health Information Network and as the prior state air surgeon for the Air National Guard. After 28 years of military service, I most recently advised the COVID-19 task force in a pivotal role for our state's whole of government response to the pandemic. As we all witnessed during the pandemic, telehealth emerged as a lifeline for patients and providers alike. We were initially fairly clunky with the use of Zoom, I'll admit that, but we got more facile in accommodating the needs of our patients. I personally loved meeting with patients in their dining room, their basements. One memorable moment where a wheelchair-bound elderly individual on their back porch on a sunny, beautiful day with their son, we did a post-hospital visit right there in their backyard. And I and my clinic coordinating their care, working with the nurse care managers and others. We swiftly adapted to telehealth services to ensure continuity of care. As another example, our urology group discovered they could provide safe, effective care and follow-up counseling to patients after a kidney stone was discovered in the emergency department. Initial scans and testing had already been accomplished, so they could fully replicate the service in the virtual space, which had previously been done only face-to-face. Payers, as we know, also responded by temporarily eliminating regulatory and administrative barriers, enabling payment for telehealth services at in-person rates during the public health crisis. However, the reality we now face is the potential reversion to pre-pandemic reimbursement rates for telehealth services. This change could undermine the progress we've made in expanding access to our patients and hinder the sustainability of telehealth as a health care delivery method. The MSMS firmly believes that the time has come to make these equitable policies permanent. Telehealth has demonstrated its immense value in improving access to care, especially in underserved communities such as rural areas, regions with physician shortages, and areas with limited access to primary care. One fundamental principle we must uphold is that the choice between in-person or telehealth care should always be a case-by-case decision made collaboratively between patients and their healthcare providers. Payers should not be empowered to favor one care modality over the other. Instead, we advocate for a system that simply provides parity and reimbursement for telehealth services compared to in-person care. Let's be clear. The standard of care and the value of what we provide is not compromised based on the mode of delivery. Whether a patient consults with a physician in person or via telehealth, the physician still performs the evaluation, determines the course of treatment, coordinates follow-up care, and ensures the highest quality of care. These actions must be appropriately documented in the patient medical record. There are no shortcuts to ensuring that our patients receive the care they need. It's essential to emphasize the equitable payment and coverage policies will not only expand access to care, but also guarantee that healthcare and telehealth remains a sustainable option for healthcare providers to offer. We need to create a healthcare system that supports the evolving needs of our patients, especially in this post-pandemic world. In conclusion, the adoption of this legislative package will ensure that physicians and other healthcare professionals are supported in their efforts to provide more convenient and timely access to their patients. It's a step towards securing a healthcare future where equitable access to care is the norm, regardless of whether that care is delivered in person or virtually. Thanks for your time and cooperation. We urge the committee to support these bills and help us build a healthcare system that truly serves the needs of all Michiganders. Together, we can ensure that the future of healthcare delivery is equitable, accessible, and patient-centered.
Thank you so much. We have time for 2 questions. Representative Thompson's going to lead us off, and we do keep in mind have 2 more people to testify after this group. Representative Thompson.
Thank you, Madam Chair. This question is for either one of our physicians. So my question is, if you have used and utilized telehealth medicine recently, have you been denied payment for the service or denied reimbursement for your service? And if so, if you could provide us with an example. And I really think that not only our board, but people in this room need to hear what it would look like if how much it costs to do an office visit and how much you charge the insurance for reimbursement versus having that same cost paid for a service via telemedicine versus. So I think we really need to get a clear picture of the difference in payment on what we're looking at. I think that might help some of us that aren't familiar with the situation. Thank you.
Yeah, so for my purposes, I'm the family doctor seeing patients. I can't tell you what happens on the back end regarding all the different payers and how they reimburse those different services. So I'd have to defer working with the MSMS to collect some data on that. So I can't speak to that specifically because, quite frankly.
Yeah, I was just going to say, if I can restate, I think for part of our question is, do you have different charges and are you receiving different reimbursements? So for XYZ procedure, are you charging differently for telemedicine visits versus an in-person office visit?
Right. Again, my understanding is that it's a hodgepodge right now, and as was pointed out before, there's different negotiations that happen with every single payer. So again, I'd have to get back to you on what that looks like for our different insurance payers.
But as a follow-up, when you are filling out your billing, I understand you have back
see.
billing, but when you fill
Sure.
out your EOB for your charges,
Right.
what does that look like?
So I, as a doc, I use what's called an E&M code.
Yes.
And then I add a qualifier that says telehealth. And then that gets submitted to the payers. And what happens in the back end, that's the magic that somebody else does.
And then do you want to respond as well?
Yeah.
Sure. And I had the privilege of working with Dr. Hamadi in the same health center, so I'm very familiar with his charges, actually. It's the same. So it's sort of a charge master. The set of fees that's associated with the services are the same, whether it's in-person or telehealth. And this is something we spent a lot of time really digging into. The biggest cost in healthcare is people, and the people costs are the same. yes, maybe the small facility or supplies cost change, but for those small changes, then the technology components and other aspects take the place of those costs. And so we dug in really diligently to this to make sure we were charging appropriately. And across the state in health centers, it's the same charge for the service, whether it's in person or telehealth. The bill packages include really important language on ensuring clinical appropriateness and effectiveness. And I know both of these folks and then all the care teams and clinicians that I've talked to, they're very good about saying, this is a service I have to see the person in person for. This is a service I can do via telemedicine, and keeping that clinical appropriateness in mind.
I guess I'm just trying to understand, if everything is working right now, then what is the purpose of the legislation that we need to change? Are you nervous that what is working right now will be stopped, and that's why we need to look at this legislation?
Yeah, absolutely.
Okay.
And we don't have certainty today, so we're still operating under temporary policies in some cases, policies that are still evolving as we go. And so the specific codes, the specific services that are covered under telehealth, those are changing. And it's incredibly important, not only for us, but for our patients, to make sure we can offer them certainty in the way that they engage with their care teams.
Okay, thank you very much.
Thank you. And I will just, again, take Chair's privilege to say we're currently under an extension of the federal orders. And so that has a date certain as well to expire. So when that goes away, we could be potentially uncovered. So thank you so much. We appreciate your testimony. Next up to speak to the importance of the telemedicine access in behavioral health and substance use disorder arena, we have Laura Huat, COO of the Guidance Center here today. And then Michael Garrett, President and CEO of CNS Healthcare, is joining us virtually. Begin when you are ready, Laura.
Hi, good morning. Thank you for having me here. As you mentioned, I'm the Chief Operating Officer at the Guidance Center. So the Guidance Center is can everybody hear me? Okay.
Is your microphone pushed on? There should be a red button.
Yeah, it's on.
Yep.
We're a large nonprofit human service agency, so we provide an array of services to more than 15,000 people a year. We provide things like Head Start, Early Head Start preschool, but our largest division is our behavioral health, so mental health and substance use disorder treatment, which I'm here to talk with you about today. We have one location in Detroit, but we primarily serve the Downriver region of Wayne County. So Downriver is 21 communities that range from urban, suburban to rural. So we have 3 communities that have rural areas in them. So we understand the value of telehealth for people regardless of what their living situation might be. And we serve all ages, so from pregnant moms all the way through older citizens. We use those services for them as well. One of our fastest growing lines of service right now is our substance use disorder treatment. So we offer outpatient therapy. We don't do any residential. It's all outpatient therapy, intensive outpatient, medication-assisted treatment for people with alcohol and opioid use disorders. And that particular program has gone from we were really, really small back in 2018 when we started growing services to meet the community needs. We were only serving about 100 people a year in that program. This year we've served more than 500, and we're set to serve well over 700 in the coming year. So it just keeps growing and growing. And our area, out of the 10 communities in Michigan, when we started deciding to grow this program, we looked at stats, and 10 communities in Michigan that had the highest rates of deaths from opioid prescription medications, 7 of those 10 were in our service area. So we are living and breathing the opioid crisis every day at our organization. Our referrals come largely from drug courts, local sobriety courts, so it's really important that we continue those relationships, and that does help save money. We're not putting people in jails. We're able to serve them in the community. This also helps our law enforcement partners, and I'll talk a little bit about that. But one of the things that we haven't talked about yet is people who are working and need our services. It's incredibly important, and one of the representatives mentioned this for her own personal story, and a lot of the people that are in our substance use disorder program have full-time jobs. And we want them to maintain their employment. That's incredibly important. So they will hop on Zoom on their lunch break and participate in our substance use disorder group therapy sessions. Those are our most well-attended sessions when we offer it through telehealth, and we offer it at a time that's convenient for someone who's working. The other piece of it too is think about life happens. It happens to all of us. You may be on the way to your doctor's appointment and your car breaks down. And those types of things for the people we're serving in our substance use disorder programs can be the very things that trigger relapse for them. So instead of not being able to participate in their group therapy or their therapy session, they can hop onto telehealth, and that can help prevent a relapse, which is so important, and that can help save lives. We don't provide 100% of our services virtually. We will never do that. There is a need to lay eyes on somebody. We do our intake appointments in person so that we can meet people, we can see them. They come into our office when they see the doctor. Sometimes the doctors are virtual, but the person is coming into our office because we want to take their height, their weight, their blood pressure. We're doing urine drug screens. We're checking to make sure that they're not at risk for HIV, and if that's the case, then we're going ahead and doing blood testing. So a lot of what we do is still in person, but that telehealth piece, and we're doing right now about 80% in person, 20% telehealth. But that telehealth is really critical. When people need the care, to be able to do that is very important. And the cost has been talked about too, and I will stress that our cost is no different. We have brick and mortar facilities. In fact, we have 18 locations throughout Wayne County, and those locations require heat. We have to pay lease costs. All of that is still the same, whether we have somebody sitting in an office meeting with somebody over telehealth or somebody sitting in an office and the client is coming in to receive in-person services. And the cost of technology like cell phones for all of our staff, that not everybody had to have a cell phone prior to this. They didn't all have Zoom. We have to pay higher rates than, it's not free for all of those things. 80% of our cost is personnel. The rest is made up of supplies, transportation, all these other things, and only about 5% is our occupancy costs. It's a very low percentage of our overall cost, and that is made up for when you talk about the additional technology that's needed to provide telehealth. So the costs really are the same. So I don't know if
Thank you so much. We appreciate your testimony. Next up on Zoom, we have Michael Garrett, CEO of CNS Healthcare, joining us virtually. Begin whenever you are ready, and welcome to Health Policy Committee.
All right, thank you very much, and thank you for having me back to testify again. My comments are going to be brief because my colleagues, Laura and Dr. Hamadi, have done an excellent job of covering a lot of things that I was going to say, but there are a few things that I would like to highlight. There weren't many good things to come out of the pandemic, but telehealth and telemedicine was. Is it convenient for a number of people? Sure, but even more important than that, it's an overall issue of access. Since telemedicine was expanded during the public health emergency, we've been able to get thousands of people more into treatment that otherwise would not have received it. Like Laura, we're a large provider of behavioral health care services that serves southeastern Michigan, being Oakland, Macomb, and Wayne counties. And we suffer from the same barriers, and the people we serve suffer from the same barriers of lack of reliable internet capable or smart capable devices, and lack of transportation. Telemedicine never has had the intention and never will replace face-to-face visits. 80 to 85% of all of the encounters that we have are still face-to-face, and it's going to be that way. Where telemedicine really helps out in the gaps that it fills is it allows us, like I said before, to get people into treatment that otherwise would not have had the option to do it. And telemedicine is very appropriate, particularly for follow-up appointments for people that have already seen the doctor, that have already seen the therapist, that have already seen the clinician, to help make sure that they stay on top of their treatment plans. But one of the things that I'd like to say about telemedicine, I am in full support of all of the bills that have been presented today on telemedicine. I want to make sure that as you go through this process, we keep in mind behavioral health care and physical health care parity. Some of you may or may not know that when the public health emergency ended, audio-only telehealth was pretty much unrestricted during the public health emergency. But once that ended, there were restrictions placed on how and when behavioral health care providers could use audio only telehealth. That immediately put about 10 to 12% of the people that we serve at risk for not having a reliable means on following up with their healthcare gains and their objectives. I don't want to speak for my primary care provider counterparts, but I don't believe that the public health emergency, the ending of the public health emergency, entailed any restrictions being put on audio-only telehealth on that side of the health care spectrum. But it severely limited what behavioral health providers, such as CNS Healthcare and the Guidance Center, could do. So as these bills move through, I would request that some of those restrictions be moved aside so that we could offer telehealth services audio only where appropriate, just like we were doing during the public health emergency. So thank you for the opportunity to testify, and I'm grateful to my colleagues for being there in person to speak on this very important issue. Thank you.
Thank you so much to Laura and Michael. We're going to go ahead and read cards in and then move along. Supporting all 4 bills on the telemedicine package is Ascension. Supporting all 4 bills, Michigan Academy of Physician Associates. And thank you to your colleagues or students for being here today with us in the room. Michigan Health and Hospital Association, supporting all 4 bills. MyBAP and Hope Network, supporting all 4 bills. Disability Rights of Michigan, supporting all 4 bills. Michigan Council of Maternal and Child Health, supporting all 4 bills. Michigan Academy of Family Physicians, supporting all 4 bills. CMHA of Michigan, supporting all 4 bills. Oakland Community Health Network, supporting all bills. Rachel Enright from Grosse Point Park, supporting all 4 bills. Dawn Sterling, supporting all 4 bills. Jennifer Ward Kolka, supporting all 4 bills from the Spectrum Autism Center. Trinity Health supports HB 4131. Candace Lake from Wedgwood Christian Services supports 4213, 4131, and 4579. Michigan Society of Addiction Medicine supports 4579 and 4580. Thank you so much. Lots of papers up here. All right. Telemedicine has really increased our residents' access to needed health care across our state, and I appreciate the bill sponsors bringing these forward and all the testimonials. We are accepting feedback and hope to vote on these bills in the very near future. Next up, we will take up House Bills 4504 and 405, the Physical Therapy Licensure Compact bill package. We will hear from Representative Fitzgerald, Josh Stump, Legislative Director for Representative Zorn, and from the Physical Therapy Compact Commission, we will hear from Jeff Rosa, Compact Administrator, as well as Brian Gilbert, President of the American Physical Therapy Association of Michigan. We're going to start, I think, Brian, if you can hold back a second, we're going to start with the bill sponsors. So,
do you mind if he sits up
that's
here
fine.
with us?
I will defer to Representative Fitzgerald.
Thank you, Madam Chair. Good morning, members of the committee, Madam Chair. Thank you so much for allowing me to testify to my bill today, House Bill 4504. The Physical Therapy Licensure Compact, or PTLC, is a state-based solution to the challenges of interstate licensure, portability for physical therapists and physical therapist assistants. It improves patient access to physical therapy services in the state of Michigan by giving eligible licensees in participating states an easier and faster alternative to traditional licensure, while retaining safeguards to protect the public. This important legislation would enable Michigan physical therapists to obtain multi-state licensure to practice physical therapy in other states that also participate in the compact, without having to obtain a separate license in each individual state. The legislation helps facilitate the interstate practice of physical therapy with the goal of improving access to health care while preserving the regulatory authority of states to protect and prioritize the health and safety of residents through their current systems of state licensure. Interstate practice of physical therapy makes it easier for physical therapy providers in Michigan to ensure the physical therapy needs of rural and underserved areas are met and to maintain continuity of care for their patients living and traveling outside of Michigan through telehealth. The compact could also serve as an important tool in attracting and recruiting physical therapists specializing in critical shortage areas of care such as women's health, chronic pain, long COVID, and oncology rehabilitation. I think it's important to note as well that currently 37 states that are part of the PTLC, or are part of the PTLC, of which 30 are active and 7 are currently implementing. Regionally, you might note that Wisconsin, Indiana, and Ohio are members of the compact, and Illinois has the same legislation introduced in their legislature as well. So with that, I'll turn that over to our sponsor from 4505.
Thank you. Good morning. I appreciate Madam Chair and fellow committee members for allowing me to testify today. My name is Josh Stump. I'm the Legislative Director for Representative Dale Zorn. Unfortunately, he's not able to attend today, but he has asked me to read the following statement. I am writing in support of House Bills 4504 and 4505 that would amend the Public Health Code to enter Michigan into the Physical Therapy Licensure Compact. I have been working on this issue since January of 2019. I believe that it was good policy then, and I believe that it's good policy now. I support all the experts and their testimonies today, and I thank Representative Fitzgerald for his partnership on this legislation. And I know that I am extremely grateful to have bipartisan support for both of these bills, and I look forward to finally resolving this issue. Thank you.
Thank you. I think next up we've got Jeff Rosa on Zoom, the compact administrator, if you'd like to join in, and then we'll have Brian's testimony. Welcome, Jeff, beginning whenever you're ready.
Thank you. Can you hear me?
Yes, we can.
Perfect. Okay. Chairwoman Rogers and members of the House Health Policy Committee, my name is Jeff Rosa, and I am the PT Compact Administrator. And I want to thank you for considering House Bills 4504 and 4505. I've submitted written testimony, and I'd be happy to answer any questions that you or anyone on the committee may have about the Physical Therapy Compact Commission and its administration. As the sponsor of the bill stated, the Compact Commission, we're an independent governmental entity that currently consists of 36 states and the District of Columbia. And each of the states, including Indiana, Ohio, and Wisconsin, previously enacted the same legislation that you are considering today. The purpose of the compact is to facilitate the interstate practice of physical therapy with the goal of improving public access to PT services while enhancing public protections. So in essence, the compact is just an alternate way for physical therapy providers who meet the eligibility requirements to obtain the ability to legally practice in the state of Michigan or in the other member states within a matter of minutes instead of the days, weeks, or months that it takes with the current licensure process. Instead of a multi-state license model in which an individual licensed in one compact state can legally practice in any other compact state with no notification requirements to the remote state, under the PT compact, when a licensee wants to work in another active compact state, the individual must purchase a compact privilege for that specific remote state. In addition to the fee charged by the Compact Commission, each state is also authorized to charge an additional state fee for the purchase of a compact privilege. The compact has many benefits for Michigan, its physical therapy providers, and its citizens, such as having a faster and more efficient process to gain the legal authority to practice in the state. It also preserves the state-based licensure system while providing the alternate mechanism for the PT or PTA to obtain the legal authority to practice in Michigan. And then finally, it also improves public protections by requiring full participation by member states in a central license and disciplinary data system, including the regular reporting of disciplinary actions to the Commission, which are then automatically shared with the other member states. The compact is widely supported by physical therapists and physical therapist assistants, including those who live and practice in Michigan. I appreciate the opportunity to be here today and welcome any questions the committee may have. Thank you very much.
Thank you. In the interest of time, we're going to hold questions until all people have testified. Brian, go ahead. Thank you.
Hi. Thank you, Madam Chair, members of the committee. I am a physical therapist in the state of Michigan. I'm currently representing the American Physical Therapy Association of Michigan as their serving vice president. I'm a former chair of the licensing board of the state of Michigan, as well as a current business owner in the state of Michigan. So I was going to comment on the number of states that are currently active, but I think that's been covered fairly well. From a licensing aspect, just to make note that every PT and PTA, physical therapist and physical therapist assistant in the state of Michigan, needs to pass a national board administered by the Federation of State Boards of Physical Therapy. This portion isn't different state to state. To be able to sit for this exam, every PT and PTA student must pass their educational portion, that they are held to the same standard and expectations. Again, no differences state to state. An issue that affects many businesses, hospitals, et cetera, is hiring in the last few years. That problem is not different in physical therapy. As I was actually preparing for today, I had heard a story from one of our APTA members that met with a physical therapy student who is attending school here in Michigan. That student is from Ohio. She is completing her final clinical rotation with an organization in the state, having a great experience. She was offered a position, signing on for about a 2 to 3 year period of time with this organization. She said she would love to do this, join in with this group. However, she stated that because of the hoops to jump through, for the sake of licensure, she's likely going to go back home to Michigan. It's unfortunate when we are, Ohio, apologize. It's unfortunate when we have amazing schools for physical therapy and we're training students from out of state, but when we have the opportunity to possibly retain them, this becomes a hurdle. As a business owner here in Michigan, although I don't live along borders, I can empathize with my colleagues who state that they have lost candidates that didn't want to go through the hassle of attaining and retaining 2 separate licenses. The compact would reduce that burden, provide opportunities to attract and retain talent to Michigan. As we heard in the previous set of bills, the concept of telehealth has also become a staple in providing physical therapy care. For any physical therapist to treat someone who may travel to another state, so for instance, snowbirds who travel during the winter months, if they leave the state of Michigan, they have to be done with physical therapy during our time frame with them. However, if we have a compact and if they travel to another compact state, we have the opportunity to continue care with them, thereby reducing financial burden and cost to the individual as well as the health system because of continuity of care. It was also mentioned the specialty offerings, chronic pain, women's health or pelvic floor care, things along those lines. The rural areas are underserved, and this is an opportunity to create a pathway for that to be achieved. One other aspect of clarity is this does not expand the scope of practice for physical therapists. It is simply about accessibility. At this point, I want to strongly encourage support of these bills, and I thank you for your time.
Thank you. We have a question from Minority Vice Chair Vanderwall.
Thank you, Madam Chair, and thank all of you for being here. And as we've worked through some of the compact issues from multiple states, I appreciate this legislation coming forward. We all know we have access issues. We all have a shortage of people that can perform these services that are licensed. And we live in a state that we're bordered, in the Upper Peninsula and in the South. Is there a projection of if we offered this, how many people this would add the opportunity to practice here in the state of Michigan?
Representative Fitzgerald.
I mean, with 30 states currently, allowing for compact use, I would say that that's I'll use some HFA language here, indeterminate. But I would believe that there would be a significant impact in terms of the competition that we would be able to compete for strong physical therapy candidates from across the country. Not only those border states, but there really is more or less an endless pool of candidates now who could then practice in the state of Michigan.
No, I appreciate that answer, and I do believe that you're absolutely correct. And we have a great state, and I know that in some of the other issues of legislation that in the past and in the future that'll come, we have people that visit our great state for 6 months out of the year that would then give them an opportunity to practice, especially in the rural areas. So appreciate you bringing this forward.
Thank you so much. We have one more compact to get through, so thank you for joining us. I'm going to quickly read in the cards supporting the 4504 and 4505, Michigan Health and Hospital Association, Michigan Occupational Therapy Association supports the bill. American Physical Therapy Association of Michigan supports the bills. On a very closely related topic, we will next take up House Bills 4169 and 4170, which would have Michigan adopt the Occupational Therapy Licensure Compact. And it is one of my bills, I will go at ease, testify, and then turn things over to Denise Henderson with the Michigan Occupational Therapist Association. If Representative Wozniak would like to join me, we will go at ease, call the chair.
The committee will come to order. Chair Rogers, you can begin when you're ready.
Thank you so much, Vice Chair Whitsett, Minority Vice Chair Vanderwall, and members of the committee. Thank you for listening to our testimony. We have very similar bills to the Physical Therapy Compact that was just mentioned. I will speak to both my bill, House Bill 4169, and then Representative Wozniak may want to give a couple of brief remarks to his Bill 4170 in this bipartisan package. The Occupational Therapy Compact is an interstate professional licensing compact for OT, which will address licensure portability. It allows OTs to practice in all states that have joined this compact. The compact authorizes practice based on a valid, unrestricted home state license in other compact member states for both occupational therapist OTs who have master's or doctoral degrees and occupational therapy assistants, OTAs, who have associate or bachelor degrees. OTs are healthcare professionals who assist people with relearning their activities of daily living, things like how to care for oneself, how to do daily tasks, treating physical, cognitive, developmental, and emotional ailments, and things like bathing, dressing, and toileting. The American Occupational Therapy Association is leading the initiative in collaborating with the NBCOT, or the National Board for Certification in Occupational Therapy. This center is also collaborating with the Council of State Governments, many of you know as CSG, and is providing guidance for multiple states joining these interstate compacts. As a practicing physical therapist who works alongside other PTs, PTAs, OTs, and COTAs, I can personally share with you that many of these workforce issues are facing a lot of our facilities, just like other healthcare professions. In fact, one of the many reasons that I still practice physical therapy a few days a month is because my hospital desperately needs each and every one of us who pick up a weekend or other shift to help rehabilitate our patients who are in need. And when we don't have enough therapists, there can be additional hospital costs as discharges of patients are delayed. You see, we are all often the specialists who help our medical teams determine the type of setting that is most appropriate for a patient to safely discharge to. And when I can't get someone on my list, I can't get through the entire list of my patients that need evaluation, they sometimes must stay over an additional 24 hours to the next day when they can be seen and assessed. So these workforce issues can have an effect on both quality of care for patients and on an institution's bottom line. The need for occupational therapy is not diminishing. In fact, the Bureau of Labor and Statistics forecasts a 17% increase in the number of occupational therapist positions by 2030. The need is growing year over year for these services, and we must consider all solutions to expand workforce access. As my colleague Representative Fitzgerald mentioned, interstate compacts are designed to have a common set of licensure requirements so that therapists can practice seamlessly from state to state without delays. 26 other states have successfully already joined the Interstate OT Compact. I wanted to touch on a couple of additional new items. This can help military families. Both OTs who have served in the armed forces and their spouses can be helped by this type of streamlining, as they are often moved from base to base around the country. It can also help our border states, like was mentioned before. I do want to be competitive with Ohio. And also our Upper Peninsula residents with the Wisconsin-Michigan border. In fact, I would argue that's probably one of the most underserved areas in our state. Occupational therapists already undergo significant education to practice in their field, and these highly educated professionals will make decisions about where to practice and live based on accessibility. Ultimately, these bills should help streamline the process and get therapists into our Michigan workforce more quickly. Representative Wozniak.
Thank you. I think the rep covered most everything that I have to say, except on 4170, this is, again, going to help patients to have more access to services and providers that they don't have now. And when we do this, we'll be able to have licensees cross over state lines as long as they're conforming to the compact rules. And once we do that, there will be more available OTs in our state. It just makes sense to do it. Now, there is a fiscal impact to that that's unknown at this time, but I think this is worthwhile going forward. Rep?
Thank you. And I know we have a couple other people to testify, but I could take questions if the vice chair would entertain it.
Any questions from the committee? Rep. Van Berkom.
Thank you, Madam Chair. The House fiscal analysis we got just says that this will be a significant cost, particularly to Lara. Do we have any estimates of what the cost is going to be for these compacts? Do we have anything we can look at other states and what has incurred their costs?
Thank you for the question. We did just get that cost analysis late last night. I'm going to defer to someone that's going to be speaking on Zoom about the fees that are associated when states join an interstate compact. So I'll let him kind of address that, but thank you for the question.
Any further questions? The committee will call the chair. The committee will stand at ease and call the chair.
The committee will come back to order. Next, we will hear from Denise Henderson with the Michigan Occupational Therapists Association with insight into Michigan's shortage of occupational therapists.
Hello, and thank you, Madam Chair, as well as the members of the committee. My name is Denise, and I am an occupational therapist. I have my clinical doctorate. I'm board certified in pediatrics, so I have a specialty certification that I provide. I am the advocacy director for the Michigan Occupational Therapy Association, and I'm also a member of the Indiana Advocacy Committee. I do carry 2 dual licenses. I've been practicing in Michigan and Indiana, and I've been practicing in Michigan for 25 years with a dual license for 9 years. And I do live on the border of our southwest area, and so I just wanted to give some perspective of the shortages in the Michiana area. 32 to 36% shortage of OT serving children and adults across the lifespan, including our elderly population. So when we look at this compact, as we say that 26 to 28 states have already signed on, with 4 more in pending legislation by the end of the year, we're looking at improving access to care, equitable access to care. So I wanted to provide a couple examples so you can put this in perspective of the patients, the clients, the consumers that are receiving or not receiving services. So for example, we already are seeing children that are in early intervention or first steps. They receive services in their home. That's a natural environment. That is an activity that's been occurring for quite some time. With the compact, that would allow individuals living in Michigan or individuals living outside of Michigan to be able to service those individuals in first steps or, again, across the lifespan. We're seeing up to 8 months waiting period for some children to get services. If this is a child with cleft palate, if this is a child with feeding, eating, and swallowing, then they are not receiving services for helping their everyday activities to eat and get the nutrition that they need to grow and to engage in school services. Across the lifespan, when we look at our elderly population, if we're waiting 6 to 8 months for home health visit, how are these individuals learning to adapt to shower, to bathe, and to safely live and age in place? So these are some services with the shortages that we're seeing currently in Michigan, as well as the opportunities outside of Michigan that could help with this compact. The other thing we wanted to emphasize with the compact, we've already heard numerous things today about telepractice, and so there would be a lot of opportunities that this could pair with telepractice. Michigan residents could still live in Michigan if they joined a compact and worked in other states, but still lived and worked here with boots on the ground here, but on the weekends or evenings provide additional telehealth practice if they so choose, and engaging in the compact with other states. The other thing that I wanted to emphasize that the National Occupational Therapy Association has already been proactive to look at this because of other states. And one thing that they've already included in the education, the curriculum, the national curriculum, which is governed by the Accreditation Council for Occupational Therapy, has already implemented training for every educational program. The 436 programs across the United States already have required legislation standards for telepractice, which would be an asset for the compact for those that are utilizing that services. The last thing I wanted to emphasize, when we're looking at other states, and I know one area that we've looked at is implicit bias and additional training. The majority of states, as we already heard with previous testimony, best practice and ethical practice. So your standards of practice do not change. The maintenance for you to maintain implicit bias training, human trafficking training, pain management training, those standards across each state, as well as what is required under our national certification and our state licensure.
Thank you so much. We are going to run out of time for questions, so people can email the chair with questions and we will follow up. Next on Zoom, we have Cameron Kiefer, Vice President of Rehabilitation Services with Ascension, joining us remotely. Welcome. Thank you for waiting patiently.
Thank you for the opportunity. Can you hear me okay?
Yes, we can.
Well, good morning, Chair Rogers and committee members. My name is Cameron Kiefer. I currently serve as Vice President of Rehabilitation Services for Ascension, and I'm also a licensed physical therapist. I appreciate the opportunity to speak with you today and submit written testimony about the importance of House Bills 4169, 4170, 4504, and 4505, both OT and PT compact licensure bills. And I'm especially glad to be able to speak in favor of Michigan joining these two licensure compacts, because I know my colleagues in other states have the ability to use this flexibility, and I'm hopeful that these bills will support recruitment and retention here in Michigan. Ascension is one of the leading nonprofit and Catholic health systems in the U.S. We're committed to delivering compassionate, personalized care to all.
And I'm so sorry, we are at a hard stop in 5 minutes because we have sessions. So if you can get specifically into the meat and potatoes of the hiring practices, that would be great.
Give you a scope of our presence in Michigan: 16 hospitals, several healthcare facilities, and we've been serving in Michigan for almost 150 years. As mentioned in previous testimony, the recruitment for physical therapists and occupational therapists is very competitive. In addition to what was cited from Bureau of Labor Statistics about OT at 17% growth rate, PT is projected at 15% as well. We're at it because so many of our neighboring states participate in the compact. We are at a competitive disadvantage for recruitment here in Michigan. And as mentioned, it will improve our ability to provide virtual care as well as care in our facilities. Ascension has several facilities that are on the border with other states, and our treatment or service area encompasses both states, making it difficult for therapists who must become licensed in dual states. We know that these bills alone aren't going to solve all of our workforce shortage problems, but it will be an important tool for health systems like Ascension to more quickly recruit and retain therapy providers, and most importantly, support our ability to provide access for these important services to our communities. Thank you for the opportunity to testify and ask for your support.
We appreciate it. Lastly, we have Dan Longston from the Council of State Governments and the National Center for Interstate Compacts. And thank you also for patiently waiting. We do have a hard stop in 3 minutes.
Thanks, Chair Rogers. I'll just get into it. I'm Dan Longston with the National Center for Interstate Compacts. I'm the director here at CSG. We facilitated the creation of the development of the OT Compact. I'm here to answer any questions that you may have. Relation to what the question that Chair Rogers got earlier, most of the compact commissions don't assess states. A couple do. Nursing assesses states flat fee of $6,000 per year. SIPAC, which Michigan enacted, I believe, last year, assesses states a fee of $10 per compact privilege issued by that state. I think there's a cap of $1,200 on that. It's important to remember that it is the member states who make up the Interstate Commission that will be determining if they want to assess states and then the amount of that. I also want to bring to your attention that the American Occupational Therapy Association and MBCOT, the credentialing organization for the profession, have each committed $300,000 to the commission's functions and operations over the next 3 years. And the Compact Commission, I know, is actively seeking grants. With that, I'll answer any other questions that folks may have or respond to them in writing after the hearing.
Thank you so much, and we will gather those questions and get them to you. Supporting the bill is American Physical Therapy Association of Michigan and Ascension, as well as Jarrett Skorup Mackinac Center. Representative Vanderwall moves to excuse absent members. There being no objection, the motion prevailed by unanimous consent. There being no further business before the committee, committee will stand adjourned.